our final plenary session this afternoon, and our focus is the prevention agenda. We heard from Rishi earlier about his and the government's intention to develop a vision for prevention, and indeed there's a green paper due in the spring. So, linked to that then, the transfer of public health to local government has placed local government in the driving seat to support the health of people in their areas. Increasing healthy life expectancy, supporting people to live at home, and the increasing integration between health and social care are all central to public health. The division of responsibilities between the NHS and councils is still a matter of debate, and it's important to consider what lessons can be learnt from the previous changes that have taken place. So, Phil Swann of Shared Intelligence will discuss the impact of the transfer of public health to county authorities, what's working, where we can do better, and the emerging findings from some CCN research. Now, this is research that the late Ian Stewart was involved in commissioning, and clearly, if he hadn't passed so in such an untimely way, he'd be introducing this session. But this was work that he was very much involved in commissioning. Jim McManus, Jim is actually my Director of Public Health. He's the Vice President of the UK Association of Public Health Directors, and he also leads in a cross-cutting sense on prevention at Hertfordshire County Council. And Jim will make the case that the public sector cannot achieve prevention outcomes without what public health and what councils are doing and what they collectively can bring to this agenda. So, let me first and foremost introduce Phil Swann from Shared Intelligence.
Thank you. Good afternoon. I'm very conscious that Jim and I stand between now and lunch, so I'm going to get straight on with it. So, 5 years on, what's the state of public health in county areas? I'm going to report on some research that we've done for the County Council's network. It involved doing non-attributable interviews in 14 county areas. We spoke to the Director of Public Health in all 14 areas, and we also spoke to some combination of the Chief Exec, Accountable Officer of the CCG, Chief Exec of a health provider, and the Health and Wellbeing Board Chair, and in 4 areas we spoke to all 4. So that's the evidence base I'm going to talk to. One of the findings really surprised me, and one of the findings forced me to change my mind about something. I'll say more about that in a second. If we go back 5 years, the statements the then government published at the time were pretty ambitious about the impact of the transfer, summarised on the first quote on the slides. They said it would lead to a 20th century public health system based on localism, democratically accountability and evidence, led by councils which embed their new public health functions into all their activities. Interestingly, words pretty similar to the kind of thing the Secretary of State for Health and Social Care is talking about today, in the second quote on the slide there. So that's the context in which this research sits. Overall, the perspective from the people in county councils we interviewed is a positive story. Everybody talks about councils having a far better understanding of public health now than was the case 5 or 6 years ago, and the people we interviewed were able to point to a large number of initiatives, particularly those involving the public health team working with other parts of local government. So there's joint work underway on air quality, active transport, child mental health, homelessness, planning, regulatory services, suicide prevention, the list goes on. In quite a few cases, those are joint work between the county council and district and borough councils. But as the quotes on the right of the slide here show, there's a spectrum of enthusiasm out there about the scale of the impact Some people talking about it being the best thing for public health ever, others saying it's made things a bit closer, the links between health and local government. So there's definitely a spectrum out there. Everybody talks positively about the beneficial impact of local authorities, procurement and commissioning processes, which directors of public health talk about as being far more effective than was the case when they were based in the NHS. Several of the authorities we spoke to talked about the evidence-based analytical approach that public health teams adding to the strategic intelligence capacity of the council, and counties in particular were seen as bringing scale, capacity and the potential for coterminosity. And as the top quote here shows, the impact of a council's procurement and commissioning processes recognised by colleagues in the health service as well as in local authorities. But, and here's the biggest but, and this is the bit that surprised me, everybody we spoke to in the health service locally was at best sceptical about the impact of the changes and in some cases extremely critical of them. I've checked the interview notes several times. This is what they said off the record. Three main concerns. One, not surprisingly concerned about the impact of reductions in resources, but no one pretending that public health budgets weren't, open quotes, raided when it was in the health service, but also concerns about fragmentation in the commissioning of some services. The bit that surprised me, a kind of deep-seated scepticism about the impact of action on the wider determinants of health, and perceptions of a growing gulf between public health in local government and the health service. And that third point is something that is recognised by the people we interviewed in local authorities. A perception of a gap developing between public health in local government and the health service. I'll come back to these points in a second. So, as I said, we've picked up among our local authority interviewees a spectrum of opinion between those who are incredibly enthusiastic about the impact and those who are positive but less enthusiastic. And going through the interview notes, am I on the right slide? Yeah. Going through the interview notes, we've identified 4 factors that seem to influence where on that spectrum individual councils are. There's something about the position of the public health function within the authority, something about the nature of the relationship with district councils, because many of the wider determinants of health relate to district and borough functions rather than county functions, something about the nature of that relationship between health and social care, and something about geography. And I forgot to emphasise this point earlier. There is real enthusiasm amongst the directors of public health we interviewed about the role of local politicians as advocates for public health, both within their council and out in the community, and an ambition to build on that. And that's seen as one of the strengths of the transfer within the people in local government we spoke to. This is the point on which I've changed my mind. I went into this research thinking that the debate that happened at the point of the transfer about the position of directors of public health in local authorities, whether they reported to the chief executive or not, was a bit of kind of DPH status stuff, that they were being a bit pompous and should just get on with it. That's what I went into this research thinking. The evidence would suggest that where the public health function in the local authority sits does make a difference. And I've been through the interview notes several times to make sure that I'm on firm ground here. And it's most certainly not all about status and position, and the skills of the individual directors of public health do make a difference, but so does the position of the function within the council. And there do seem to be two worldviews emerging. One worldview, the public health function sits at the corporate core of the council. The task of marshalling action on the wider determinants of health is centre stage, while not neglecting mandatory and uncommissioned services. In this picture, the DPH either reports direct to the chief exec or has regular meetings with her or him, and this is an aspirational, place-focused function. That's worldview one, summarised by the quote on the right-hand side here. Worldview two, public health is seen as a people service, sitting alongside adult and/or children's services. Main focus is often on commissioned services, with less progress being made on the wider determinants. And in this setting, financial pressures tend to be centre stage. The quote on the left sums up this perspective, with the DPH saying the complexity of her or his world is not yet fully understood. We're still influencing from the side. So those two distinct worldviews, and the evidence we've got from interviews in the 14 places leads me to that conclusion. District councils. Also two worldviews, to be honest. A quote on the bottom left there summed up the view of quite a few directors of public health. A two-tier local government makes my life more difficult than my colleagues who work in unitary areas. A quote on the right, actually a DPH saying that they were working really closely with their districts, doing a lot of good stuff, and other working relations are preferable and better than they were before. And in the middle there, a chief exec who told us that the collaboration between the public health team and district councils was one of the things that was galvanising more effective working relationships between the two tiers. So seen as being a challenge in some areas, a driver of collaboration and good working between counties, districts, and boroughs in other places. If we come back to this question of the relationship with health for the final few minutes, there is no doubt that where the Director of Public Health and his colleagues put effort into maintaining good relationships with their colleagues in the CCG and in health providers, relationships are better than elsewhere. It seems to me that is largely a matter of capacity, because it takes time and effort. It's not will, it's capacity. Where the capacity is made available, relationships are different. But reflecting on this, and I'll be interested to see whether Jim agrees with this or not, reflecting on this and rereading the interviews, it seems to me that there is an unresolved debate between local government and the health service about the primary task of public health now in its local government setting, and the debate about the balance. Are you nodding? Oh, yeah, good. The balance between emphasis on the wider determinants of health and a more clinical focus is unresolved, and for as long as it remains unresolved and that discussion not being completed, is going to be a problematic relationship. And I think this quote on the bottom right there from an influential national stakeholder in the public health world, that this issue needs to be grappled with and resolved quickly, is one of the most important quotes in the report, I think. So finally, before I shut up, I think from our work, there is an enormous amount of shared learning out there in your authorities on issues such as how to wield the wider determinants of health, this organisational setting question, how to work effectively with districts, how to work with the health service. I think there's scope for CCN to share good and emerging practice across authorities in a way that it hasn't done so far. And finally, there needs to be an open, honest, substantive discussion with the health service about the role of public health in the current context. Thank you very much.
Thanks, Phil. Refreshing to hear such objective feedback. It gives us a lot to think about.
Good,
Yep.
Thank you.
Jim.
Thank you. Afternoon, everybody. I just want to pay tribute to that because you've done a piece of work that is faster, almost certainly cheaper, and deeper than the same version commissioned by the Department of Health 3 years ago that we still haven't seen sight of. So that's good. The experience of some of my peers is that when we left the NHS, they couldn't get rid of us quick enough. And now actually many of them want us back. And it's this false dichotomy between is public health a clinically focused service or is it a wider determinants? In reality, there has to be a bit of a both and. But personally, I am one of the people who thanks God that we're in local government for all sorts of reasons. Simply looking at the leadership in my council, you know, I have 2 cabinet members here today who have done the public health and prevention role, one who is doing the public health and prevention role. You'd never have gotten that in the NHS. I'm going to make a case that prevention is not going to be delivered without councils. Hopefully by the end of it, some of you might agree. My key points are actually prevention needs a systems approach to work. We've just put through our prevention strategy in Hertfordshire. We have a public health strategy and we have a prevention strategy about what the rest of the county and the council can do about keeping our population thriving in all dimensions. So why should you care about prevention in an era of growth? Well, you can't compete with China if your population can't get off the sofa. Is a fairly simplistic view, but I think it's accurate. And the NHS is busy reinventing its own clinically led prevention. So we've heard Matt Hancock's prevention vision, which talks an awful lot about individual responsibility, as if every succeeding generation since 1948 has had an increase in its loss of willpower to stay healthy. That's not the case. It's much more complicated than that. And I think if we just simply continue the narrative of chuck money at the NHS, we will become unsustainable. One of the projects we're doing in my area, and this is Youth Connections and the Youth Service are doing it, is helping GPs understand adolescents. So we're getting better throughput, better outcomes for adolescents, and that wouldn't happen without the council doing it. The World Bank priorities are here because I have to refer to something other than myself. But you can see actually they talk very simply about the conditions for human flourishing are the baseline for prevention. So what is it like to work in a situation where the NHS has had year-on-year growth and youth services have had year-on-year cuts? Answer, activity is displaced to the NHS. The bulk of prevention sits with local government, as I'll show you in a couple of seconds. The individual responsibility discourse used in current policy has been ditched by almost every other developing economy in the world except America. But it remains enshrined in England, and it doesn't work, and it never has, and it never will. It's a part of the story, but just one part of the jigsaw piece. This is what I think of a very simple county council life course diagram. So I'll use the pointer, so someone's about to have open heart surgery. But you can see from early years, you know, health visiting, the bulk of things that the NHS provides for newborn babies is actually provided by local government, commissioned by us as part of the NHS. Right through to end of life, where we do safe and well checks, enablement and a range of other stuff. Culture, libraries, social care, addiction treatment. These some of these were brought in with public health, some of these have been there forever. You can actually get into addiction services in England 98% of times 3 times as fast as you see a GP. And we commission those. That's local government. So why can't the NHS manage that when it has 187 times the resources for it? This is an NHS life course offer. And actually you can see that if you compare the two, the kind of things that we do in local government across the life course are actually much wider and longer than the NHS. We do not have a health service, we have an illness service. I know that's a truism, and you're welcome to these slides. So any attempt to deliver prevention from the NHS will not work without us doing our role and being adequately funded for it. This is a local government association schema, which is a Greek word for a diagram that's a bit up itself. Sorry. And you can see here that actually, even if you look at economic development is actually quite crucial to our health and well-being. So local economy, community, lifestyle, transport, built environment planning, these all have an impact on our health and well-being greater than the impact of our health services. And local government does prevention cheaper than the NHS. So the National Diabetes Prevention Programme has cost £100 million for an average weight loss per person of £7.7. Most local authority services deliver greater weight loss than that in a third of the time. And in fact, if you're in Wigan, you'll lose £6.4 in about 4 weeks. But that's just because my opposite number will nag you. The National Child Measurement Programme, more children than ever measured since we came across from the NHS. I'll talk about sexual health in a second. Teenage pregnancy, I'm going to give you a quick example of. But primary care outcome variations in the NHS are still sliding. Sliding massively and stubborn. So these are the sexual health figures for England. I'm working with the LGA on a publication called Local Government Delivers, which actually proves my thesis, I would argue, and we'll do a county council's version as well, because the CCN staff have asked for one. But these are the number of new sexual health infections in England. Note, since we transferred from the NHS, new infections have been going down. Look at the increase in attendances at sexual health clinics. So lots of people are getting physical activity, however brief. But you can see, actually, we've coped with a significant increase, 300,000 extra people in sexual health services, while bringing attendances down and cutting the budget. That's an example of transformation. The NHS is not good at doing that, and I speak as someone who's been an NHS director. There's teenage pregnancy, 60% drop since 1998. Why should you care? Because actually every young mother returning to education saves various agencies £4,500 a year. And for every child prevented from going into social care, on average it's a £65,000 saving. That's local government's work. That's not the NHS. We have the levers. So we can deliver. I'm going to talk about varicose veins because it looks like it's an exciting topic. This is the England rate for varicose veins. Now, why varicose veins? Because actually, I think they're a good sentinel of people coming into social care. Look at the variations. There's the England rate, and these are some counties. This is northwest Surrey. This is Leicestershire and Rutland. Look at the variations in that performance on there. Why should you care about how the NHS performs? Because it's costing your social care departments money, quite frankly. Look at that. And that's been stubbornly the case since 2014. And yet we've seen significant amounts of money poured into the NHS to change that, and it hasn't. This is a liver disease diagram. I'm not going to go into detail about it, but half of us in this room have got fatty liver. I have liver inflammation, which was a wee present from the chemotherapy I was given when I had cancer. And if you start with a liver insult, which is your kidneys coming up and going, "You crap, you are," but a liver insult, so some kind of injury or inflammation, the slippery slope to cancer and cirrhosis is fairly significant. And I'm not going to be a Scot who's got non-alcoholic fatty liver disease. I won't get back in across the border. But that is a significant predictor of cost to social care. Now look at the variation. Look at every other country in Europe. Liver disease is going down. Look at the black line, the UK. We're going up. Lifetime cost of someone with liver disease, 4.5 million. Look at that. We've added about 1.5 billion to the NHS bill and to social care. This one is years of life lost from liver disease. Now, it's quite simple to tackle liver disease. Sort it out by drugs, diet and lifestyle. I was offered lots of drugs, which I frankly don't need. Physical activity is more than effective enough for where I am. But look at the variations in outcomes for liver disease. This is not an NHS picture that can do prevention. I could paint this for 100 other outcomes, and indeed I have got the slides for it. And if you look at it, this is NHS growth additional to the baseline budget since 1979, all the way up. The amount of money going into the NHS has not kept pace with productivity of increasing disease outcomes. And it's right that Hancock is focusing on prevention and what the NHS does, but we mustn't have local government cut out of the equation for that. We really mustn't, because actually this won't work. This is necessary, but it won't work without us doing our bit. I'll skip over these. So I think we need to do prevention very differently. First of all, we need to conceptualise it as a wider system, where the NHS needs to do its bit. It really does. So when I had cancer treatment, I was given no advice on rehabilitation, no advice on learning to walk again, no advice on physical activity. And there are people who had my type of cancer who are still walking with a stick 5.5 years later. I did that for myself. We need to do it as a system. But that means we need to be very clear about the local government role in prevention. And that's from stopping young people coming into care, which Hertfordshire has made significant strides in, all the way through to actually helping people get into employment. The NHS role does need to be articulated. It needs to perform much better. We do need a life course approach. You know, 90% of children in counties are still having eye and hearing tests. That's better than a lot of other places, and it's better than it was under the NHS. That's a really crucial predictor of work and employment success later. And we do need a disease approach for people who have disease, but that is not the be-all and end-all of it. This slide is one that's found its way into our STP. Often what you get is a lot of NHS discourse about, you know, eat apples and broccoli and white fish. Actually, we need to start with the people who are costing us most money and reduce the curve of severity and cost. And if we do that, we really will see a step change in our outcomes. But the NHS isn't delivering that right now. I'm going to finish with this diagram, which is the costs in adulthood of childhood problems by a colleague of mine called Martin Knapp at the London School of Economics. And you can see actually criminal justice in red. Huge costs in adulthood. The NHS can do little, if anything, about that. Local government can. But the bulk of money that's just been announced for mental health in children is going into the NHS. And yet we know there are, in fact, I've just peer-reviewed the National Guidance on Public Mental Health, which is being published next week. There are about 20 things that councils can do that will radically reduce that curve. So I'll stop there, you'll be glad to know. And all these slides and more can be found on our website, but if you want a copy of these slides, I'll very happily share them with you. And that's a quick rattle through.
Jim, thank you. So, colleagues, we've got about 10 minutes for questions, if we can have the lights up. And before we get the microphones out, Jim, just the key point about the NHS being sceptical, what steps will overcome that scepticism?
So personally, I think, first of all, local authority leadership, elected members talking to their NHS counterparts. I think secondly is provide the evidence that local authorities deliver and can deliver and do deliver, and actually just provide hard numbers and data. And I think the third thing is show them we can deliver it quicker and faster than they can. So the National Diabetes Prevention Programme, we could have delivered significantly cheaper. So those would be my top 3 steps, if that's answering your question.
Okay, yeah, thank you. Okay, so some questions. I've got Richard Roberts down here. Phoebe? Yes. And then we'll take some more. Yeah.
Thanks,
Richard.
Jim. Tour de force, as usual. So I think Phil posed us almost a question as to kind of whether the NHS should have public health or public health should be the local government. I don't think anybody in this room is now in any doubt as to where that should lie, not least of which is the most pertinent point that the levers, we've heard this throughout the presentations that we had in the last day and a half, that the levers lie with local government and the leadership lies with local government. So the leadership of education, place, spatial planning, health, environment lies with local government. So why wouldn't you want, which is all the determinants of health, so if you want healthy and thriving residents and communities, why wouldn't you want your public health to be part of local government? And then I think the question that's raised is where is the local leadership of health? I think that's the question for us.
Okay, whilst we move across, just on that, Phil, just to reflect on Richard saying that, you know, the answer is obvious, but your research was saying that there was clearly a mixed view on that. And what...
Yes, I mean, I absolutely agree with what has just been said, but the fact is that when you talk to, it's especially people in CCGs, they remain sceptical of the impact of action on the wider determinants of health, which is why I'm with Jim, show the data. The thing that surprised me is that there are people within the health service who are on the point of being prepared to argue the case for a transfer back, and that really surprised me. And for me, the answer is early conversations at a local and national level to articulate the kind of argument you've just seen in Jim's slides, to genuinely make the case for what you've just said, but as well as all local authority public health teams putting effort into maintaining that link back into the health service, because in some places it has been neglected.
Yeah.
And hence the importance of CCN's advocacy of this particular issue and the research that that Phil has been leading. So, yes. Is that you, John? No, it's not.
Thanks. Jerry Wickham from Wiltshire. I'm the Cabinet Member for Adult Care and also Public Health. Now, David, a number of us sat in on we started our work early on Sunday, despite everybody else, with Grant Thornton, and we were talking about the whole issue of where we were going to go forward. And it's not really a question, but it's just really an observation from personal experience that we're finding, and it's this issue of leadership. We've had to force our way into the STP. Now, I don't know how many of you sat around here now actually have any active involvement with the STP, but I viewed it, and I was involved right from the beginning, as it being a financial recovery plan for the acute hospitals. And in fact, it's more than that. And I now find myself as the chair of the STP. And I think we've got to step up to the plate and get in there. And as a consequence of that, we've now got a prevention agenda in there. Whereas before, all we were looking at is how long people were sitting on trolleys in A&E and that sort of thing. And I think it's in our gift to actually move forward, because then that's the way we'll get hold of some of that money and push it down to prevention. So it's not really a question, but just an observation as to what we're finding.
Yeah, and I comment on that by saying that we had a corporate peer review of public health, and then we've had a corporate peer challenge of the council, and feedback from health stakeholders is that they do want us, they are asking us to exercise leadership. Now, as a new leader, I find that quite daunting, candidly, and I don't know what the answer is locally and the way through that. But yes, when asked, health keep on telling us that they are expecting to see leadership from local councils. Any more questions? Roy from Hampshire. Thanks, Phoebe.
Roy, Hampshire. I'm interested on that on STP because I dub them, and maybe it's my fault, as the secret thought police. We're not allowed to know when they meet, where they meet, what they talk about. So I might be raising some questions there. No mention of the health and well-being boards. I thought they were meant to be welding these together. Is there more that we could be doing to make them more effective?
Jim?
Yeah, I mean, I think the great thing that health and wellbeing boards haven't been able to take up is NHS quality. My advice of what you want your Director of Public Health to do for you in the NHS is three things. Get stuck into those areas of clinical quality that will cost the council money if they don't improve. Get stuck into the prevention agenda, and then help you translate, because most of us have been NHS directors, the arcane bits of the NHS back. And you don't want to have the kind of scary conversations I do about, you know, do you give Avastin to this person for stage X of cancer? That's kind of stuff best left to your technical public health team. But you do want the Health and Wellbeing Board, I think, to take oversight of where the NHS is contributing to the local area, and some Health and Wellbeing Boards are a bit light on that. You really should have them interested in NHS quality because it's costing the council money.
I've then got two questions in the middle here. Can you just put your microphone a bit closer?
Yeah, sorry, I'm a member of the Health and Wellbeing Board in Cornwall. We're not really quite sure what it's for as yet. Oh, that's got it there. But you mentioned about you mentioned in your research about the idea some directors of public health were interested in the idea of counsellors as advocates, and did they detect a problem that whereas NHS professionals would be non-judgmental in the people they were dealing with, if you're talking about addiction services, say in a council context, there might be elected members who would be responding to the idea that, and I'm using addiction services as an example, they might be driven by the idea that it's money wasted on the undeserving, and you could get, in a local government context, political arguments that you wouldn't get within the NHS.
The conversations we had with directors of public health reminded me that at the point of transfer, the thing that lots of directors of public health were nervous about was the role of these weird things called local councillors in their world, which they hadn't been used to in the NHS. The one thing that all the DPHs we talked about in this piece of work were positive about was the role of councillors, and some of them were surprised by what they had experienced, and genuinely talk enthusiastically about members being some of the best advocates for public health within the council and back in their communities. And you know better than me, you're all councillors. It's a bit of public policy that councillors get and are prepared to talk enthusiastically and increasingly knowledgeably about, and the transfer of public health into authorities has strengthened the knowledge base from which they can have those conversations, and that I think is the biggest single benefit of the transfer, to be honest. Health and wellbeing boards. I used to be the expert on health and wellbeing boards, having done 4 reports on them for the LGA, and it's about I think it's 1 or 2 years since the last report we did. I think that the picture of the effectiveness of health and wellbeing boards is still mixed. But when we did our last piece of work, the most effective health and wellbeing boards were those that had genuinely developed a place focus and were absolutely clear about the health and wellbeing priorities in their area, and in a kind of changing sea of STPs, integrated care systems, health and care integration, were rock solid in being clear about what the health and wellbeing priorities of their place were, and were making the case for those priorities in whatever settings either the board or the members of the board, such as the Director of Public Health, a council leader, council portfolio holder, had access to. And it was that resolute focus on place which was the key attribute of the most effective boards.
Okay, and then there was a question, Victoria? Yes.
Malcolm Brown, also from Cornwall Council, on a somewhat different tack from Cornelius, which is an unusual. I wanted to ask about evidence and intelligence, because I was very interested by the point Phil was making in the results of the survey, which bears out my contention that bringing public health officers into local government is very good from the whole point of view of evidence and data gathering, because they are a lot more rigorous than is possibly the history in local government. And I would also suspect that that's one area of local government which has suffered pretty badly from the cuts in the last few years. I was also very interested later with the Hertfordshire presentation, in particular the strap line, the two words underneath every slide, information and evidence, which are words we don't hear enough in local government. We hear lots about strategies. We don't hear enough about information and evidence informing policy development. And so if it's the case public health can raise the standards throughout local government, I think that's something we ought to welcome.
Okay, Jim, do you just want to say anything about information and evidence?
Yeah, I mean, I think the key thing is most public health information people have had far more training to a higher standard than a lot of... That's not a criticism. And there are riches on both sides. And if you can get them to work together in a way, it can enrich it. So one of the things my evidence team has done, we've helped bring in several millions of pounds by helping voluntary organisations use the JSNA and data to target national funders. So milk us and sweat your assets, because I think you're right, that we're not being, in some places, we're not used as much.
Okay, that brings our time to an end. Can I ask you to thank Jim and Phil?